everyone, and welcome to today's Innovation Engagement Hangout on Payment Transformation and New Payment Models under the Affordable Care Act. Today, we're featuring ONC's Kelly Cronin, Director of the Office of Care Transformation, a new office dedicated to providing strategic direction around transforming healthcare through health IT and facilitating health IT-enabled payment and delivery system reform for physicians and other providers. We're also really excited to be joined today by Malay Gandhi, Managing Director of Rock Health, who's going to be moderating today's discussion. So really quick before we get started, some housekeeping stuff, we'll leave a couple minutes at the end for open Q&A. You can ask any questions, either Malay or Kelly, using the Q&A function within the Google Hangout window, or if you're having any trouble with that, feel free to post any questions to the event page itself, and I can pass them along to Malay and Kelly. So with that, let's go ahead and get started. I'll turn over to Malay to kick off the conversation.
Thanks, Maya. I think, first for the group, maybe Kelly, you can explain to everybody sort of how ONC fits into departments and agencies, HHS, where you're situated within the government.
Sure. So ONC was set up 10 years ago as a part of the Department of Health and Human Services, so it's in the executive branch, and there was actually some back and forth about where should such a function sit, because really our charge is to try to coordinate across the executive branch. So our mission is a bit beyond Health and Human Services in terms of how to coordinate all the sort of federal policies and programs that relate to health IT and what we're trying to do with our mission. But we do sit within the Secretary's office in HHS. And we just recently went through a reorg since we're sort of pivoting now into a future where we're really focused on healthcare delivery system transformation and really thinking beyond the EHR incentives program and a lot of what we've done in the last several years, which has been enabled through the Recovery Act, or high-tech as we often call it. We're now sort of thinking more broadly about going back to our full mission and how to sort of deliver on interoperability across the whole system.
So you talked a bit about your mandate. How would you relate it to payment reform and the work that's going on at the Center for Medicare and Medicaid Innovation?
Well, we're really, in many ways, inextricably linked, because if we want to move to a system that's really going to be much more interconnected, patient-centered, and really driven by value. A system not only that's really information-rich and able to measure value, but also pay based on the value and outcomes that are achieved by all providers, then we really need sort of that underpinning infrastructure to be able to get the data, the clinical data and the cost or claims data in such a way that we can truly measure the quality, outcomes, and efficiency of the care that's delivered. But also, just as a part of the normal care delivery process, it really does need to be delivered in different ways. So while we talk a lot about payment reform and needing to be able to have the infrastructure to measure value, we also really need the infrastructure to be able to connect the providers that are delivering care. So it's not just siloed site of service care delivery, but that people are being managed as not only the whole picture of the patient, but managed by a whole team of providers, so that all your needs are being taken care of, and they are all treating you, whether they're in different places or the same institution, they're treating you as a team. So in order to do that, we need to be able to share information across settings, across providers, and have sort of a longitudinal record, a care plan, really all the information that any provider would need to make good decisions about your care and be able to plan with you about how to effectively manage your care and health.
So it sounds like you're saying that technology is really underpinning this value-based payment transformation. But before we get really deep on those components, like the key health IT components, can you take a step back and talk a little bit about value-based payment broadly? I think there's so many things that have happened before health reform, and now with health reform, we hear terms like pay for performance, we hear accountable care organizations and ACOs, we hear bundled payments. Tell us more about all the different value-based payment mechanisms that are being piloted and tested today within Medicare and even more broadly.
Yeah, it's a big question that I'll try to start to answer. And this isn't, sort of my portfolio per se, but it's one I've worked with a lot and with my counterparts in Medicare and Medicaid and on a state level. So there's a lot of existing authority pre-Affordable Care Act that lets or enables CMS to do some forms of pay for performance or value-based purchasing. So, for example, the physician quality reporting system was started several years ago under the physician fee schedule for Medicare Part B. The inpatient quality reporting and related, provisions to try to start to see how hospitals could be benefiting from forms of value-based purchasing was started pre-ACA. But with the Affordable Care Act, there's now new authorities to test new payment models that could improve care, achieve better quality while reducing costs. And those new service delivery models and payment models are being tested in a variety of forms. And as you mentioned, sort of the ACO portfolio is one form of sort of shared savings, if you will, so that an organization of providers or provider network can take on financial accountability and accountability for health outcomes for an assigned population of Medicare beneficiaries. And in some instances, it's a multi-payer agreement where there's other commercial payers or Medicaid that's getting into the same kind of arrangement. So those are really picking up a lot of traction, and over 5 million people are now covered across just the Medicare side of those programs. So there's the Medicare Shared Savings Program, which is actually a permanent program in the Center for Medicare that's outside the Innovation Center, and that's where a bulk of the ACOs are now. That's the program they're participating in. And there's sort of more pilot programs like the Pioneer model, which is going faster towards a risk-based model of payment. They tend to be slightly larger, more clinically integrated, more sophisticated organizations getting into that program. And they're testing to see sort of how will that work. And then over time, they could evolve this permanent Medicare Shared Savings Program to adopt some of the features that are successful in the Pioneer model. And then an advanced payment program is another spin on, or another form of accountable care where smaller physician-based organizations that perhaps don't have a lot of access to capital can get some upfront fees and funding from the Innovation Center if they qualify for it to then invest in their care coordination infrastructure. And working hypothesis is that if they get a little extra money up front, then they could perform better and perhaps achieve shared savings more quickly than they would have otherwise. So there's that accountable care portfolio. There's also an ESRD model around that, and that's sort of a big chunk of a lot of what's happening. But then you mentioned bundle payments. There was actually an existing demo pre-ACA on a series of bundles, a lot of cardiac, sort of hip and knee replacement bundles. So the idea there is to take hospitals and some, post-hospital stay care around a given episode of care and bundle all those services together and pay for it. So you're automatically sort of creating more accountability around that, say, 90-day period where someone's getting care around a given procedure or episode. And it's really forcing a lot of care coordination and really accountability of what's happening, not only financially but clinically, but within more defined parameters. And so those are being tested now on a larger scale through the bundle payments for care improvement, and it's across 4 models. Some of them involve just hospital care, some involve post-acute care, and long-term care. So there's different arrangements across those 4 models to figure out what works best, and after they have that experience, they then have the authority under any of these new models they're testing to scale them into permanent programs. So that's really what's really new and different under the Affordable Care Act, is you have this ability to test, but also scale if they end up working, and the actuaries do a very rigorous analysis and say, is it really saving the Medicare program money? And if it is, then they can make it into a permanent payment program. So there's over 20 of these programs going on that are sort of in a testing mode. So it's a pretty big portfolio. And it's growing, so they really are in the next sort of phase of planning out this portfolio and looking at how they can support practice transformation on a large scale, since that really is a very important underpinning to make all this work. You really need a strong primary care and specialty care infrastructure for a lot of these care coordination models to really work and scale. They're looking at what more they could do perhaps in specialty care. Long-term and post-acute care, value-based purchasing is another area that's been addressed by, actually even in the for those of you who follow the sustainable growth rate debate around physician payment, the SGR fix this year, while it wasn't what they thought it was going to be, it did have some provisions on value-based purchasing in long-term care. So there are a lot of things in the field now that are being tested, and there's a lot in the pipeline. But I guess an important point for those of you who don't live in this world and aren't into it day to day, there's a lot actually happening under the existing Medicare and Medicaid programs that is outside of the Innovation Center. So, for example, in the physician fee schedule, they are finalizing a new billable service for chronic care management, which is very similar to sort of how private payers and how some of the demos have paid for care management in PCMH models, primary care medical home models. So in some instances, they have existing authority under their regular rulemaking that they can actually scale some of these new kinds of payments that are needed to really get to a reform system. So if we start, for example, to pay for chronic care management in a way that really gets patients more coordinated care across primary care specialists and hospitals, and they have a care plan, their multiple chronic conditions are better managed, you'll likely see reduced cost and improved quality. So there's that going on. There's a lot of work going on on the Medicaid side, both through waivers to the Medicare program on a state level, that's state by state, sort of transformation plans that are enabled through a negotiated process with the federal side of Medicaid. And then there's state plan amendments that are enabling things like health homes, so they can do more behavioral health and primary care integration and get paid for that in a shared savings model. So there's really a variety of efforts. And the other piece of Medicare that's also getting a lot of traction is trying to get out of getting out of institutional care into home and community-based care for those patients who have needs for support, long-term post-acute care kind of support, but they may not necessarily need to be in a nursing home or a skilled nursing facility. They could be cared for very well in the community or at home. So there's a lot of different efforts, like Money Follows the Person and programs that are helping with that, that also is reliant on being connected with your provider and your care team. If you're going to be at home, you don't want to be home and not be able to, be connected with your geriatrician, your primary care doc, or whoever is caring for you, other than perhaps a caregiver at home. So there's lots going on, I guess.
Yeah, I think for an entrepreneur, they might be overwhelmed by that. There's so many things happening in the government. If I were to abstract sort of what you were describing there, broadly speaking, the goals are to provide, the most efficient, high-quality care possible, and the government is using a wide variety of incentives, but generally we can say the underpinning is using financial risk as one of the key incentive levers with providers, so moving some of the financial risk to care providers. So from your perspective, an entrepreneur is thinking about that, a world that's moving towards highly efficient, high-quality care, the mechanism, the lever being financial risk. What are sort of the key health IT components that they should be thinking about, enabling technologies that they could be building and successfully selling to an ACO in order to align themselves with these types of organizations that are living under these payment models? What are the key building blocks or components, technologies that are necessary?
Yeah, that's a great question. And while, financial risk is sort of, it is the ultimate goal, there's sort of a spectrum of activities that are going to be going on to sort of get to that risk model. But regardless of sort of where you are on sort of the, how far along you are on the pay for value scale, you do need these sort of underpinnings, as we mentioned, and the different kinds of health IT functionalities. One that's really critical is making sure that you can exchange information across the providers that are caring for a patient that you're accountable for financially and clinically. So if you have a primary care doc and you got 5 specialists and a community hospital that are all caring for a cohort of patients, you need to make sure that they can share information back and forth about their care. Ideally, they all be using a common platform or some way of documenting a comprehensive care plan, so you all are actually working, they're all actually working together as a team on the same plan for medications. They know what the labs are, they have a complete picture of the patient, and they're not all prescribing different things and not trying to reconcile it. So in order to really work together as a team, you need that platform, and that involves both information sharing about the patient over time, and it involves having really a good handle on the care plan and making that a shared care plan with the patient. So the other aspect of that is, if you want the patient really engaged, and all these models really encourage a lot of robust patient engagement. The technology and the innovation really in this space to be able to reach the patient effectively, educate them, engage them, make them part of a decision-making process. If they have options around a treatment or options around how they manage themselves, then they should be able to engage with you in that, and their preferences should be known and understood. So I would say there's a huge amount of innovation going on in this space, and I don't know that anyone's figured it out. There isn't like a perfect scaled solution, and a lot of it's being sort of highly customized by ACO or by provider group, depending on what they already have and what they think is particularly innovative and useful for the kinds of patients that they want to reach.
Yeah,
so beyond connectivity and patient engagement, the other big area which folks always talk about is sort of data aggregation and analytics. And when I mentioned before having like the data infrastructure for measuring value, you need to actually have that data warehouse, the ability to actually get your claims and clinical data merged and clean and be able to actually report out on what's happening. So you need the ability, you need that warehouse function, you need integration, you need mapping, normalization, and then the ability to actually visualize the data and show your provider what's happening. And then they can use that to proactively manage their patients at risk.
I mean, you have these hundreds of ACOs out there, and that there's some building block components. Many of them have implemented solutions today. As you look out into this space, what would you say ACOs are looking for but still haven't found? Where are the big unmet needs or gaps in technologies today? Is it around the connectivity? Is it around the patient engagement? Is it around the analytics? Or is it some other area that's really the big gap in sort of managing these populations if they're an ACO?
Yeah, I mean, we don't have perfect data. I mean, we've gotten a lot of public input on this issue in the last year. We've had a lot of dialogue, and there's, some surveys. But from what we can gather, there's gaps in all those areas. The one sort of low-hanging fruit that a lot of people talk about is having the ability to do alert notifications. So just having visibility into the population you're accountable for. When do they go to the ER, or when do they go to the hospital? And you may not know about it because they're going to ERs or hospitals outside your network that you're not connected to. So if you have the ability and you have an alert notification system in your community or with the hospitals in your medical neighborhood, you're able to have visibility into when are these patients showing up, and are they going to be sort of at risk for a really high cost event that you could have averted or you can better manage. So having that alert notification is actually technically pretty easy to get going, and it's not a huge investment, but there's a lot of gaps across the country, and a lot of places in the country don't have that capability. So we know it's really valuable. We've heard a lot from ACOs that they want and need that. The ones who have it are really using it. I would say analytics, a lot of people talk about, and they are fascinated by, and they think that's sort of #1 priority. But I think, general wisdom is that you know, not everyone's quite sophisticated about what's really under the covers of those products, and they don't really know what truly to invest in, and how much do they need to invest in sort of their claims warehouse versus like a fancy way of integrating clinical data and getting to a really robust set of analytics. You know, we're actually quite interested to try to advise the market a little bit better about what would be a really sensible investment strategy that would allow for quick early ROIs for ACOs if they have, let's say, a set budget for health IT and data architecture investments. What's going to get them to shared savings in year 1 and year 2 and year 3, and what do they invest in that, you know, sort of first 3-year period, just to keep them afloat, because not everyone's making money. And if this kind of model is going to actually scale, you want to make sure that they're in the know about what are smart investments that are going to actually get them to shared savings so that they can have revenues to grow this model.
Yeah, you know, having dug into some of the data around this, like there is a wide range of performance in the shared savings ACOs, and so how are the organizations thinking about sharing best practices? You know, using a certain type of solutions or certain types of processes to manage patients, manage population health. Are you seeing a lot of sharing amongst the companies?
Sharing savings across, you mean the provider organizations and the vendors, or across the providers in the network?
Yeah, for all of these ACOs, right, you have hundreds of ACOs out there. Are they sharing amongst each other on, you know, best practices, whether it's on solutions or processes? Is there a lot of sharing going on?
I think so. I mean, there's a couple different sort of learning networks going on. Brookings has had a long-standing one before there was even really a Medicare ACO program, and there is there's other efforts that CMS is trying to organize to help participants in the Medicare Shared Savings Program. The Pioneer models had sort of a learning system. So yeah, there are efforts like that underway. I think that it's pretty well recognized that there probably needs to be more support, though, because in the early years, particularly for organizations that don't have a lot of experience with clinical integration, like rural physician-led ACOs, where the docs and the hospitals have never really worked together in one organization or really worked out a lot of nuances with care coordination. It takes time to actually build that up. And to have more best practices around how to do that would probably be really useful.
What are you seeing in terms of the core functionality of electronic health records? Obviously, we've seen great wide adoption since you know, HITECH was passed, both in ambulatory and inpatient side. Do you see them being used to help drive any of the key building blocks you were talking about, whether that's connectivity and interoperability, analytics, or even some of the patient engagement? Where are you seeing electronic health records playing a big role?
It's a good question. I mean, there's sort of a baseline step, and it's really just it's just one piece of what is needed for accountable care. So if you think about computerized physician order entry and clinical decision support, you know, you clearly want to be able to make evidence-based decisions at the point of care, so you're not ordering expensive advanced images that aren't absolutely needed. If you could, you know, if you had low back pain, you could refer somebody to physical therapy as opposed to going to, you know, an expensive advanced image down the road. So there are ways to, you know, have the point of care application, the EHR, enable really good clinical management that's evidence-based, and that's going to be also just your, you know, clinical data that you want to then share in your warehouse and do all the analytics from. So it's a core building block, and some of the functionality of the point of care is very useful, but a lot of what you need to manage across an entire medical neighborhood is way beyond that. So really it's the network system and it's the middle layer of applications that are really important to be able to manage across a whole provider network or a whole population of patients. So a lot of the registry functions, for example, if you want to query up all your at-risk diabetics, I mean, you can start to do that in an EHR, but you're not going to have complete visibility on their total cost of care unless you're like a Kaiser or a Mayo and you're fully integrated, but that's not most ACOs. So the registry functions in an EHR are probably only going to get you so far. You'll need sort of a population health management tool that will be on top of that or at an ACO level.
Mm-hmm. What about on the patient side? How do they fit into this, like this health IT picture, new payment models, their satisfaction and how they're involved? Because it seems like we're describing a lot of things that are going to be done in benefit of the patients, but how are we really measuring that, their satisfaction with the healthcare system?
Yeah, it's a great question. I mean, that's historically been done through sort of a consumer survey we call CAHPS, and that's going to be sort of the way to do it in the near term until we get to an infrastructure for patient-reported outcomes. There's a lot of people doing great work on how to develop patient-reported outcome measures, and then we are now thinking through, well, what's then the standards and applications and infrastructure that's going to allow you to scale that so that you can actually get a patient's experience as a regular part of doing care. There's actually some really interesting work going on at some academic medical centers, I think Mayo might be one of them, where they are trying to make that as a routine part of care delivery. So they're going to automatically capture data about the patient experience. So if you want to then go to say, well, how are you doing? Or if you want to look at all of your ACO patients, you're actually going to have the data to compare across all those patients that are captured in the EHR. So we're, I would say, early days in figuring out how we're going to get to a better way of actually measuring patient-reported outcomes as enabled through health IT, but it is absolutely a priority.
Okay, excellent. So if you're sort of you're an entrepreneur today and they're listening to this and they say, hey, I've really developed something awesome that could hit one of these gaps or one of these key building block components, what advice do you have for them? How do they sell to an ACO, which for an entrepreneur, maybe an early stage company, seems pretty intimidating? And I think a couple years ago, I worked with one of our companies to cold call every ACO, because CMS has done such a nice job of publishing all their contact information. And I had low receptivity 2 years ago. I can only imagine how many cold calls they get today. So what advice do you have for an entrepreneur who thinks they have something great, has maybe shown it in a small scale pilot, and wants to really roll it out with one of these larger ACO organizations? What should they do?
Yeah, that's a great question. So, I mean, I think you have to be pretty savvy about your market segmentation. So there's a lot of different ACOs. You know, you've seen one ACO, you've seen one ACO. So the large academic medical centers that own a lot of physician offices, you know, are going to look for something if they've invested heavily in Epic, and maybe you have to layer on top of that. That's a very different situation from a physician-led group that might be urban or rural, but they're, you know, on 10 different EHR platforms, and they might have, you know, 3 different HIE vendors they have to deal with. So in some instances, it's trying to figure out, well, what is your segment of the market you're trying to go for? Are you trying to, you know, are you thinking that there's going to be open APIs in a few years and you want to build on top of that, on top of EHRs? Or do you think you're going to be more like an integrator? You're going to take data from a lot of different places, sort of like the Humedics model, and, you know, do a lot of mapping and normalization and a lot of cool analytics on top of that. Or do you have something that could maybe work in a lot of different environments, but is really going to be patient-focused and be innovative and really get the patient engaged and tethered to their care team? So I think once you understand a little bit more about your, you know, where you want to go with your product development, it's probably wise to do some homework on the ACO market itself and understand what is the kind of provider or kind of market where your product will really thrive. And the more reference implementations you have and sort of proof of principle of results, I think the more compelling it is.
Okay, that makes sense. I also want to remind the audience, if they have any questions, they can click the Q&A button and they can ask questions as well, because I could go all day with Kelly asking lots of questions. So audience, feel free to ask away. But as we're waiting for some of those questions to come in, Kelly, I want to follow up on that point. So, and I'm going to belabor this because we work with startups, as you know. Our companies are doing great. You know, they have these early early stage proof points. They've done case studies. In some cases, they even have published evidence for their results in peer-reviewed studies. What are the right forums to present that in? Where do you see, like, I always like to call them big buckets of customers. So where are they all getting together? Where are the ACOs spending time? Like the people who are leading these organizations and looking for technology solutions. Where can we find big groups of them? Where are the forums that this discussion and introduction of new solutions and technologies is happening?
I don't know that there is one forum for that. There is an ACO association.
Okay.
It's fairly new. Cliff Goss is heading it up. So that's just sort of as a point of contact. That's an association that has like touch points to the market of interest. Some the CMIOs or CIOs go to HIMSS, and HIMSS is a huge meeting, as you know, but to the extent that ultimately the purchasing decision is usually made by a CIO or CMIO at a large organization anyway. That's one place that they usually go to. Or CHIME is another organization it's a CIO association. And there's also the Brookings ACO Summit, where a lot of ACOs go. There's one coming up next week in DC. So I would say either the very large ACO summits is where you're going to find a lot of them, and usually there's like a health IT talk or track in some of those. There are some specific like boutique conferences on health IT and ACO, but I don't think they get like a large chunk of the ACO executives to show up for them. I think it's usually a mix of, vendors and states and providers.
That's really helpful. I think it's good that more of these forums are popping up, and hopefully more best practices sharing is happening amongst the ACOs, so companies can find an easier way to scale versus, I love the way that you put it, once you've sold to one ACO, you've sold to one ACO. So very hard today to build scalable technology companies in this space, but hopefully over time that'll start to change. What do you see as kind of the big opportunities for new data being captured today? Like, how is some of this stuff around quality and administrative data? We've just really never captured it at this level of scale before, and it's required now, obviously, to get paid or to capture your incentives. How's that data really being converted into information, new knowledge about the industry? Maybe you can share some anecdotes of things that we've learned from capturing this data, or ACOs have learned from capturing quality and administrative data.
And turning that into knowledge?
Yeah.
I mean, that is sort of that's a lot of their secret sauce. I mean, I think what a lot of people are very interested in now is being able to do predictive analytics on not necessarily the high-cost, high-risk patients that you can pretty well identify in a lot of different sort of analytic approaches. It's the folks that are already costing a lot of money that you can subset out and identify and manage. But there's a lot of interest in trying to figure out who's going to be going into that subgroup that's really going to drive your costs. So who's most at risk of the really expensive hospitalization in the next year, and trying to then proactively prevent them from being that high-cost, high-risk patient. So I would say some of the newer approaches, and really looking at the clinical data, because you get a lot more, a much deeper picture and deeper data on what's actually happening clinically with the patient from the actual clinical data, no surprise. So claims data is a good, rough picture of what's going on in terms of diagnosis and past procedures and their total cost of care. You obviously get costs from claims. But if you want to really know what's going on a physiological level, or how the whole clinical picture looks with a patient who might become really sick, you're going to get a lot more data from your EHR and your clinical data set. So I would say there's a lot of interest in looking at that in aggregate and doing more predictive analytics and trying to use that knowledge to then, really manage that subpopulation that could be your next high-risk cohort.
So yeah, I want to ask one follow-up on that, and then I want to take some questions from the audience here. But if you look out at ACOs, and I know you've just said we have to segment them and look at them separately, but just sort of as much as you can make this a generic answer, where do you see the focus today in terms of patient populations? Obviously, these organizations are bearing some risk now. Do you see them focused on the highest risk patients, medium risk patients, or even doing the wellness and lifestyle stuff for low risk patients? I mean, and that's a really long-term bet on managing the health of the population. But where is the focus today on, if you were to look at these risk layers of very healthy people versus very sick people, and everyone who's probably like most of us, which are reasonably healthy but have something lurking around the corner, where's the focus of ACOs today?
Yeah, I would say it is on the high risk, high cost cohort, because especially in these early years of ACOs, they don't have infinite resources to invest in trying to really tightly manage everybody. So they have to be judicious about where do they spend their care management dollars. And if they know that, say, they're dual Medicaid and Medicare beneficiaries that are frail, elderly, or have a lot of behavioral health issues, whatever the combination of conditions are, they tend to be very high cost and at very high risk. And if you spend some resources on managing them well, it usually pays off. In fact, if you look at the past experience of the physician group practice demo, which was like the ACO precursor program in Medicare, L.A. Fisher did an analysis of this. They actually found that where the cost savings were achieved were in the dually eligible population who are high cost, high risk. So I think there is sort of this, first priority, let's get them covered. That's not to say they aren't interested in wellness and they aren't wanting to sort of get at that, that next, population that is, just on the cusp of becoming high risk, high cost. But from what I can gather, and this is just my opinion, I think most of them are really trying to focus on the most expensive and most sick patients.
Okay, that makes sense. Do you see, I mean, speaking of sort of taking on risk and where to focus, have you seen any payment models, this is a question from the audience, where any payment models where the risk is actually shared with the patient? Is anybody experimenting with that?
Be really neat. I don't know of any off the top of my head. I mean, there's a lot of forms of cost sharing going on in terms of benefit design and just cost sharing schemes in health plans. But I haven't seen a shared savings model that has actually taken the patient into account. It would be pretty innovative, but I'm not aware of one.
Okay, yeah, I mean, I think there's a lot of stuff going on around with insurance companies and being able to do some stuff around premium incentives, 20-30% there for biometric measurements and healthy lifestyle programs, but I've not seen anything like that either, where the shared savings would go back to the patient, which would be pretty interesting. So another question from the audience, in the context of the importance of patient engagement and patient experience that folks are focused on today, where do you see the future of personal health records and sort of patient-controlled longitudinal health data versus ACO-controlled, which is more of what we were discussing, HIEs and data exchange between providers, but where's the patient in control of this data and the personal health record?
Well, I think that there's a lot of interest in having sort of a consumer-mediated exchange model, but I don't know of many places in the country that have actually been able to make that work. And my take on it at this point is that it's very hard to scale a solution, particularly for patients who do see a lot of providers, to have a patient in control of their own record and then have it consistently updated and shared as needed with providers that you're seeing. It's a lot of it's a workflow challenge. In some cases, it's a technical challenge. But I even know from my own experience trying to set one up for my father, who sees many different doctors. All these different offices have different EHR platforms. They don't want to take individual requests from one PHR. To share a summary record, even if it's standardized, and they should be able to share a summary record using a standard that's part of certification. So technically, it's a little bit challenging, but I think it's just a workflow issue. If you had, say, 5,000 patients in your practice, and they were using 20 different PHR platforms or a way of, sort of maintaining their own longitudinal record, an office would not want to interact with 20 different solutions. It would be the workflow would be so complex, and then you magnify that by 1,000 dealing with a hospital and the number of patients they serve. So I think to the extent that that model is enabled and scaled statewide. I mean, if you look at New York, they have a really interesting model, and that SHINE, sort of their state health information network in New York, is really comprised of a lot of different local health information organizations, and then sort of an enterprise bus or network on top of that. And they will have consumer applications on top of that state network that will have longitudinal data. I mean, that's sort of their plan. I think there's a lot of innovation in the works around that. And that's actually a pretty interesting model, because then the consumer doesn't have to do all the negotiation and updates with all their providers. Mm-hmm. It's someone else taking your longitudinal record and then having an application sit on top of that. So I think to the extent that if the complexity is taken away from the consumer in managing a longitudinal record, but they still have control over who sees it and how it's maintained, then that seems like something that could really work. But there's just not that many places in the country that actually have a longitudinal record.
So frictionless entry and patient control of access provisioning you see as sort of the future of personal health records, if we're going to have them.
Yeah, I guess.
Okay.
I don't really have a crystal ball there, but yeah, there's a lot of challenges up front in terms of where the market is today and the degree of interoperability we have.
I mean, and it's interesting, you mentioned the state of New York, and I think Massachusetts has done some work in this area too to create this kind of statewide infrastructure for healthcare data. I think you called it an enterprise bus. But then we also see large companies like Apple and Samsung, and supposedly Google next week is even going to announce their own health, personal health platform, which this is kind of their second go around at that. Where do you see the role of the states versus these private companies, tech or otherwise? How much is important for the states and governments to solve versus private companies?
Well, I don't know if it's the role of government to solve or to think about technology solutions per se, but I do think that federal and state policy can help enable a longitudinal a platform that gets you to longitudinal records. And I guess the challenge with any vendor trying to do this is sort of, who do you want to reach, and what's ultimately the functionality supposed to be doing for you? Because I think in many ways some of these larger companies that haven't had a really big presence in the healthcare market, they may not know it in depth, and they're getting away from their core, competency as an organization. They just don't understand the complexity of the healthcare system to know that you can't get data from all these different sources easily integrated into a personal health platform and then expect to scale it. So I think that some of the lessons learned from some of the failures is that we weren't quite ready to have sort of a really big innovative push. Now there's always disruptive innovation, so whoever figures it out could really make it work, but I think right now if your product is relying on a longitudinal record, it's a little bit challenging. I think but there's a lot of interest in that. Maybe, I don't know if this is realistic, but it could be there's a research base around sort of patient activation and what do you need to do to effectively engage somebody depending on their level of readiness for changing their behavior and changing their health. And if your application can really get into really help somebody depending on where they are in that spectrum of readiness to change their lives, then that could be really innovative. But I think if you're dependent on having a longitudinal record underneath it, unless you're working with Kaiser or Mayo or the VA, you're likely not going to have the data you need.
So, I mean, I think one of the interesting things here is that, 5 years ago, the world was very focused on encounter data, whether that was the claims data or the clinical data generated at the encounter. But I would argue, and we released a report on biosensing wearables, that 2 orders of magnitude more data about patients' clinical state is going to be generated directly by them through devices they own and control, through apps and services they own and control. So the need for perhaps bringing in the healthcare system's data is going to be a less important need than the ones for patient-generated data. So we had a question here from the audience about which they would appreciate to hear, like, which ACOs are actually leveraging this patient-generated data, getting in front of that. We know it's important to integrate claims data and clinical encounter data, but what about patient-generated data? Where does that fit in? And have you seen any ACOs that have been starting to incorporate some of that type of data and how they're using it?
Yeah. It's a great question. I don't know off the top of my head like who is really capturing a lot of patient data. There's been a lot of discussion about trying to make sort of a health risk appraisal or an upfront sort of assessment of a patient's overall health and risks reported by them as a part of a wellness visit and a part of care delivery and captured in the EHR, or even captured in a portal, but somehow really made part of the clinical management process. Because it really does give you a much better picture of the overall patient. And I think clearly there's a lot of interest in remote monitoring and again, trying to get people out of institutional care. So the degree in which you can manage them well at home and get their generated data from home, whether it's from their CHF monitor or whatever device or data they may have that could help keep them well managed at home, that's becoming increasingly important. And I think there have been a lot of pilots done with remote monitoring. A couple of our Beacon communities did that and showed a lot of success and pretty significant reductions in readmissions. So there's a lot of innovation going on in that space. I think that there's still a lot to work out in terms of interoperability and how you capture this data in a reliable and standardized way and make it really part of the overall clinical management process.
Sure. So, I mean, I think my last question for you, I think if we've taken all the ones from the audience, my last question is just besides today's webinar, which is great that ONC is hosting these and engaging in conversations with the community, but besides today's webinar, what's the best way for an entrepreneur or anybody out there who's interested to engage with the ONC and your team to discuss payment reform and ACOs, health IT, everything that's concerning you and concerning the community?
Oh, that's a great question. I don't know if I have an immediate answer for it. We do have a lot of, ongoing public meetings through our Health IT Policy Committee. We're going to have a whole new work group on advanced payment models, advanced health models, and they'll be looking at all these issues and getting public input on them. We want to do more of these kinds of hangouts, and we constantly meet with stakeholders. We're now in the process of trying to get a lot of input on an interoperability concept paper we put out for sort of where we're going in the next 10 years. So that's an opportunity to talk to us about how all these things fit together. So yeah, there's lots of different things going on. You can always check out our website to see sort of what's the most current. And Maya and I are happy to be points of contact. I'm volunteering Maya, but I'm assuming she wouldn't mind doing that.
Well, that's great. That's what our office is here for.
And so with that, let me turn it back to Maya to close us out. Kelly, I want to thank you for taking the time to speak with us today. This has been great. Always encouraging to hear how much the ONC is doing to further our health IT initiatives across the country. So thanks for your time, and I'll give it back to Maya now.
Great. Well, thanks, everybody. Thanks, Kelly and Kelly, for your time and the informative discussion. Audience members, if you have any further questions or feedback, please do leave us some comments on the event page, and we'll be sure to get back to you. And if you'd ever like to keep track of our upcoming Google Hangouts, please follow the ONC on Twitter at @ONC_HealthIT. Thanks so much, everybody. Have a great day.